to something, or to remember something, or to know something.
Understand, Prof.
Yeah.
Okay. So the
So for your
for
future presentation, for your future
okay,
presentation, that's how you have to mention.
paham, Prof. Okay, so for the fourth one, at the end of the presentation, we can enumerate complication of twin. We also can state the definition, types, and complication of twin to twin transfusion syndrome, and describe the lines of management of DDDS during pregnancy, and recognize various delivery methods based on fetal presentation and problem. Okay, so first by the definition. So multiple pregnancy is a term used to describe pregnancy with more than one fetus at the same time, most commonly twins, but may also include triplets and quadruplets. So we also can classify the multiple pregnancy by the number of fetus, the zygosity, the chorionicity, and also the amnionicity. So the incidence increased by years. You can see here, this is the incidence in England and Wales per 1,000 maternities. So from 1982 to 1992, it increased by years. Traditionally, for the incident, we also can use Helen's law, which is 1 by 85. Some books say 80 per pregnancy. For example, twin. So we just put number 2 here. So it will be 1 over 85 per 85 square. So if triplets, we just add 3. Okay. All right. So there are two types of zygosity, which is fraternal and identical, which is dizygotic and monozygotic. You can see here, dizygotic, where two eggs are released from the ovary, and each egg will be fertilized by separate sperm, means two eggs with two sperm, and each embryo implants in the womb separately. So the results will be they will have separate placenta and also separate inner sacs, which we call as DCDA, which is dichorionic diamniotic. So monozygotic means one egg is released from the ovary and fertilized by one sperm. So there are three
Condition.
sorry, Prof. Okay. Okay. There are three conditions might occur, which is the first one is early embryo splits before implanting in the womb, which is occurs in 1 to 3 days. So it will become DCDA, which is two placentas and also two inner sacs. So if the uh, separation occurs within 4 to 7 days, it will become MCDA, which is monochorionic diamniotic, which it will be one placenta and two inner sacs. And if the separation occurs 8 to 12 days, it will become MCMA, which is monochorionic and monoamniotic, which is one placenta and one inner sac. So I have a question for the floor. What will happen if the separation occurs more than 12 days? Anyone?
There is another condition, conjoined twin.
Yes. Okay, betul betul. So if the separation occurs more than 12 days, so the condition will call conjoined twins ataupun kembar siam lah, Siamese twins.
And for your info, the DCDA, okay, the dizygotic always diamniotic. Okay, dizygotic always
Diamniotic.
Diamniotic, as well as dichoronic. Okay? Dizygotic always dichoronic, diamniotic. But for the monozygotic, can have 4 conditions: dichronic diamniotic, monochronic diamniotic, monochronic monoamniotic, and conjoined twin, based on the cleavage of the cell. When the cleavage occur later, close to uh, more than 12 days, it may become conjoined twin. If the cleavage or separation occur less than 3 days, it's similar to the dizygotic, dichoronic diamniotic. If cleavage occur 4 to 7 days, monochronic diamniotic, and if occur at 8 to 12 days, there is no membrane in between. Single placenta, monochronic, chorion refer to the placenta, amniotic is refer to the membrane. There is no membrane. So the baby is living together in the same pool, without separation. What's the potential complication? The umbilical cord can be entanglement, or can be torsion between the umbilical cord because of the fetal movement is without separation. Next, okay, just an extra explanation.
Okay, thank you, Prof.
Right.
Right. So the symptoms are uterus can be larger than expected days in pregnancy, increased morning sickness, increase in appetite, excessive weight gain, especially in early pregnancy, and fetal movement felt in different part of abdomen at the same time. So these are the symptoms of patient who has multiple gestation. All right. So the investigation we can do is the HCG level, because HCG level basically HCG is released by the placenta. So when there are more more than one placenta, the HCG level will be increased. And alpha fetoprotein level. So alpha fetoprotein is a type of protein which is released by the liver of the fetus. So when there are more than one fetus, so it also can increase the AFP lah, alpha fetoprotein level. And the common investigation done is ultrasonography. Okay.
Okay, wait.
Okay.
Go to the, okay. So before the uterus is palpable, patient will have a symptom of pregnancy. So symptom of pregnancy common for the layman person. It's a morning sickness. Morning sickness. Before the you are able to palpate the uterus. So increase morning sickness, increase appetite, okay, and probably when the gestation a bit later, the uterus is actually palpable, but it does not correspond to the date. Okay, so when the uterus is palpable, it's actually not corresponded to the date because contain more than 2 of the fetus. Okay, and fetal movement fact, this is later in pregnancy now. Okay, this is later in pregnancy. And for investigation, beta HCG we don't do as a routine, beta HCG, as well as alpha fetoprotein. So what we do normally is ultrasound examination. From the ultrasound examination, as you can see here, there are 4 fetuses. Okay, so you are able to diagnose multiple gestation by ultrasound. Beta HCG level, alpha fetoprotein level is not indicated, but if you measure, it will be high because of multiple gestation. Okay.
Okay. So these are the ultrasound findings. So you can see there are you can see in the ultrasound, which is the number of gestational sac and the number of amniotic sac within the chorionic cavity, the number of yolk sac. You can see here, this is the gestational sac, the number of amniotic sac. This is the fetus B. This is the yolk sac, and we can also locate the placenta and the intertwin membrane. We can see if dichorionic diamniotic, we can see a lambda sign, the membrane. If you see the picture here, this is the lambda sign. Okay, so this indicates dichorionic diamniotic. If monochorionic diamniotic, we cannot appreciate the lambda sign. We only can see the T sign. So this is the T sign. So this assessment of chorionicity later in pregnancy is less reliable. So the assessment relies upon the fetal gender, the number of placenta, because later basically if you want to see the lambda sign and T sign, we have to take ultrasound during the first trimester. So the importance of knowing this to what you call that, to know the the risk of multiple pregnancy, which will discuss by my other friends. I think that's all from me.
Wait. Go back to the previous. Ultrasound, you can see the number of IUGS. Okay, how many IUGS that you able to see. So it's referred to the gestation. Okay, the number of the fetuses. Okay, the number of amniotic sac within the chorionic cavity. So that is will give you some idea about the type of twin, number of amniotic sac within the chorionic cavity. The number of yolk sac is similar to number one. Okay? Each gestational sac will have their own yolk sac. Okay, and each baby will have their own yolk sac as well. So if you see two yolk sac in one IUGS, okay, without separation, so meaning that the baby probably, the fetus probably is a monochorionic monoamniotic. Okay, and placenta location, placenta widely separated. So it's indicate that this is dichorionic diamniotic. If the placenta is close together, possible of monochorionic, but some condition is still be able dichorionic diamniotic condition. Intertwin membrane such as lambda sign and T sign. Lambda sign, as you see there, okay, there is a tissue in between the amniotic sacs. Okay, so the tissue is indicating that there are two separating amniotic in which the placenta can be present in between the membrane. So this indicates a dichorionic. So T sign, there is no tissue in between the amniotic, meaning that there is a single placenta. So this is monochorionic. But you still able to see the intermembrane. So the membrane for the monochorionic is slightly thinner than the membrane of dichorionic. Because the membrane of monochorionic only has two layers, okay, compared to the membrane of dichorionic has 4 layers. Okay, that's all.
These are my references. So the next presenter.
Okay, Assalamualaikum to Prof and everyone. Today we'll be talking about the complication of multi-fetal pregnancy and also the complication unique to monochorionic pregnancy. So, for complication of multi-fetal pregnancy, so we have maternal and fetal. So if you see the maternal, basically, of course, you have two or more. When we're talking about multi-fetal, will be two or more fetus in the womb, in the uterine. So of course, the physiological changes like in the pregnancy, like increased cardiac output, the volume expansion, the hemodilution, all the weight gain will be much more increasing compared to singleton pregnancy. So the mother will probably will experience nausea, vomiting, much more increase than the singleton pregnancy. And then of course anemia, because of there is increase of you have two fetus, so the needs for iron is much more high, iron and folate requirement. And then you have it will be much more increasing the pregnancy induced hyperemesia and preeclampsia, and also polyhydramnios, because the mother will the two fetuses urinating, so they will much more amniotic fluid. And also preterm labor occurs around frequently occurs, and the mean gestational period for the twins is 37 weeks. So because why the preterm labor happens because of over detention of the uterine. And then we have malpresentation, which is, I think, the second baby will the second fetus will have much more problem in malpresentation. So antepartum hemorrhage, and then you have mechanical distress because two baby, and then prolonged labor, and then of course there will be operative interference such as like C-sec or probably forceps delivery. And then postpartum hemorrhage because of the uterine in multiple pregnancy, the uterine will be much more over distension, and it leads to uterine atony, so it can lead to postpartum hemorrhage. And then for fetal, so the risk for abortion is much more higher than singleton, and that is the abortion occurs, I mean the miscarriage occurs in first trimester. It will become vanishing twins. The twins that die just vanishes. And then also appearing twins, meaning that they miss the the initial scan, they miss the twin, and then probably around later gestation they see there's another there's another fetus in the pregnancy, in the pregnancy. Okay, preterm birth, same as preterm labor, it's very common. And then fetal anomaly, and also discordant growth of meaning there's a different of growth in the twins, intrauterine death of one of the fetus. And then we have this is very unique to monochronic complication pregnancy, which is twin transfusion syndrome. And then we have cord prolapse. This is when they share the same amniotic sac, monoamniotic sac, so the increase of cord prolapse and the cord entanglement, like locked twins. And then the perinatal mortality also increased compared to singleton pregnancy, also compared to the singleton pregnancy. Go next.
Well, I need to add.
Okay.
Okay, for the maternal nausea, vomiting, anemia is actually because of the hormone. Nausea, vomiting because of the SHG hormone is higher. Okay, in the multiple pregnancy. Anemia because of hemodilution. PIH and preeclampsia because of the condition is well associated with multiple pregnancy. Okay, pregnancy-induced hypertension and preeclampsia. Polyhydramnios, okay, commonly associated with multiple pregnancy in case of twin-to-twin transfusion syndrome. Together with oligo, there must be poly and oligo to diagnose a twin-to-twin transfusion syndrome. Right? Okay, and preterm labor because, as you mentioned, over distension of the uterus. Malpresentation, of course, if the baby is twin, okay, so relatively there is associated with malpresentation. One because of poly, another one because of ego, or both of the fetus actually Catholic be present in the lower part, but both actually at the similar level. Okay, so both compete the pelvic brain and both unable to enter the pelvic brain. Okay. Antepartum hemorrhage is quite common because of the larger placenta. And dyspnea palpitation, of course, because of overdistension, cause more dyspnea and palpitation, the mother. Okay, prolonged labor, yes, because sometimes because of malpresentation, can have a prolonged labor as well. Operative delivery is quite common. Postpartum hemorrhage because of overdistension of the uterus. Okay, for the fetus, abortion, as you mentioned, similar to the vanishing twin. If one of the twin is aborted or disappear or absorbed by the system because of um, the co-twin die quite early. So the twin cannot be developed. However, the surviving twin will survive. Okay, preterm birth because of overdistension and because of others associated problem, PE, preeclampsia, and so on. Fetal abnormality is about twofold in twin. Discordant growth in the twin to twin transfusion. One is big, another one is small. Okay, one fetal death, one fetal demise. Okay, twin to twin transfusion syndrome. Cord prolapse possible as well. And locked twin, if the twin, the leading twin is breech and the second twin is Catholic, and the head is actually locked during the delivery process or during the SRON, okay, before patient admitted to the hospital. So the baby, one baby delivered with leg, okay, however the head stop, okay, due to is locked in between the head in the uterus. That is considered locked. Okay, next.
Okay, sorry, my mic was open. Okay. This is the twin transfusion syndrome is a complication that only unique to monochronic pregnancy. So what you need to know about this twin to twin transfusion syndrome first it's unique to monochronic pregnancy. So in all monochronic placenta, they share the same anastomotic connection. Although like some vascular connection are found, although vascular connection are found in nearly all monochronic twins, approximately only like 10% of monochronic diamnetic pregnancy and 5 of monoamnetic pregnancy will subsequently develop to TTTS, which is and it's a chronic need. And the TTS is a condition that can affect the twins gestation that share one placenta. This disorder highlights the importance of determining the chronicity and amnesty of all twin gestation. This is why it's important in twins to have the ultrasound scan. Okay, go next. Okay, so basically in monochronic pregnancy, we have 4 type of vascular connection, which is arteriovenous, veno-arterial, and veno-venous. And then what could have, I mean, like what could go wrong in monochronic pregnancy is that the keyword here is the unidirectional flow can occur in this AV anastomosis and result in shunting of blood towards one twin and away from the other when the AV anastomosis are unbalanced. This is what they call twin to twin transfusion syndrome, where there's a unidirectional flow, which is mean that there's one flow in for this type of vascular connection, where what happens is we call it donor and recipient baby. So the donor will shunt the blood towards the one another twins, causing it to be unbalanced. So go next. I will explain more. So in this syndrome, the blood is transfused from a donor to from a donor twin to its recipient sibling, such that the donor may eventually become anemic and its growth might be restricted. In contrast, the recipient become polycythemic, meaning there's more lot of red blood cell, and they may develop circulatory overload, manifest as hydrop. So basically, this baby, the baby donor baby, will become hypovolemia. There's very less blood, and the recipient baby will have hypervolemia, which is later I will talk about the complication that leads to the complaint. So why this TTS will harm the baby? So in TTS, the donor twin has low blood volume. The donor one, so the baby A have low blood volume, and then while the recipient have high blood volume. So what happen is later on, the baby will produce because renal hypoperfusion lah, because there's less blood volume at the donor. So the fetus will produce less amniotic fluid and less urine. This will lead to progressive emptying of its amniotic sac until the donor becomes stuck, like a stuck. I think there's one case in what where the TTS baby is stuck and wrapped in its own membrane, while the recipient will do the opposite. So the donor will become oligohydramnios, while the baby B will become polyhydramnios. When it does the opposite, it will urinate so much that there is a massive amount of amniotic fluid, so polyhydramnios, and it will distend the amniotic sac and the uterus. And then eventually it will lead to cardiac failure, cardiac overload, volume overload, because there's so many volume in the baby. Yeah, and then well, the small baby will become it, and then the progress for the outcome for prognosis, I think the donor will have better outcome than the recipient. And then go next.
Wait,
Go to
wait,
the-
wait,
Okay.
wait, wait. The idea of the blood has reached the baby A as a donor is wrong. Is wrong. So the process, the event is actually occur at the placenta before reaching the donor twin. The blood supposed to be going to the donor, however, it's shunted to be going to the recipient. Doesn't mean that the baby receive the blood and give back to the baby B. So it's actually the things occur at the placenta before reaching both fetus. So there is a unequal distribution of the blood between two fetuses. Okay, so the blood that goes to the baby's A is small in amount compared to the blood goes to the baby B, because of the anastomosis at the placenta. Okay, so this actually before reaching the baby. So the distribution is unequal. Okay, as you able to see the portion of the placenta, you see the portion of placenta, there is a very tiny line crossing the placenta, right? Okay, about 1/3 is actually about 1/3 is actually belong to the baby's A. About 3/3 is belongs to the baby's B. This is to indicate that the amount of blood, okay, that actually unequally distributed to the fetuses. Right? Those smaller baby is considered donor, even though they are actually not reach the blood, not get the blood. It's actually a matter of in unequal distribution at the placenta level. Understand?
Okay, understand. So it happens at the placenta.
Happen at the placenta, not as donor you talk lah. We get money, then we give to the another person. No, this is the money is actually still away from the baby. So is the money is still at the bank lah, at the bank. in the
Okay.
at the bank, but the unequal distribution of the money. The bigger baby get 3/4. The small baby only get 1/4 of the money, right?
Yes.
So that's why the baby A is considered poor, poor outcome, poor baby. Baby B is richer than the baby A, because if you talk about money, the money is at the bank. A at the bank, which is based on the distribution, 1/4 only for the A and 3/4 for the B. Understand?
Understand?
Understand, Prof?
Very good, right? So this is basically when they bring out the placenta in mono, in the twin transfusion syndrome. You can see the color they put on the injection. So the left twin have yellow artery, while the right twin have red artery. And then you can see when they put the injection, there's like one place where they share the same anastomosis. You can see the yellow. One become yellow and then masuk, and then the red. No, not that one. The apa tak yang the arrow, the black arrow. Yeah. You can see this is the way the place they share the same anastomosis. Okay, that's for Nila. Okay, and then next. Oh, okay, never mind. Okay. This is the complication for monoclonic multiple gestation. So as just now I already said that the donor fetus will develop oligohydramnios, while the recipient fetus will develop severe polyhydramnios or hydramnios, and then due to increased urine production, renal hypoperfusion, and the virtual absence of amniotic fluid in the donor sac prevents the fetal motion, giving the rise to the descriptive term of stuck twin. So this is the list of complication for recipient and donor. So what happened is polycythemia. Of course, the recipient has more blood and also leads to hypertension, polyuria and polyhydramnios because more volume overload and circulatory overload, and then it also leads to cardiac failure because there's so many of volume being overloaded, and hydrophytalis meaning edema of the fetus, and also can lead to fetal demise. And then while the donor, anemic because there's less blood, and then lead to hypotension, and then oliguria, and then oligohydramnios, and then circulatory infection insufficient, and also can lead to IUGR, growth restriction, renal failure, and fetal demise. This is
Okay, you see once the donor has no liquor at all and no bladder, and will be pushed to one side. So we call condition as stuck twin. So the baby cannot move, even around the uterus or at their place, cannot move. The hand, the leg stuck there. Why? Because there is no liquor and the co-twin has polyhydramnios. The amniotic fluid is actually pushing the baby, give some pressure to the baby. Walaupun even though they are in the same uterus, being pushed by the polyhydramnios. We had one pregnancy, okay, last week we delivered because of stuck twin problem. And both baby now in the NICU under ventilator because both deliver prematurely. One twin is 1.1 kilogram and the small twin is 800 kilogram. Okay, the gestation was at 30 weeks, 30 minggu. Right? So the donor one, which actually has more problem at the moment with lung hypoplasia because of no liquor. Okay, so the lung is poorly developed. So they ventilate with high setting because to inflate the lung, okay, which is very stiff, they have to use high setting, and the complication of high setting ventilation cause leaking of the lung. So creating a pneumothorax, okay, pneumothorax, okay, or pulmonary hypertension, secondary to the pneumothorax. So there is a lot of problem with the twin to twin transfusion because most of the baby delivered preterm. So the preterm complication of the fetuses. Understand?
Yes, Prof.
Okay.
Okay, next we'll be talking about how to diagnose twin to twin transfusion syndrome. According to Society for Maternal Fetal Medicine 2013, TTTS is diagnosed based on two sonographic criteria. First, a monochronic diamniotic pregnancy is identified, meaning the single placenta. Second, polyhydramnios defined by the largest vertical pocket, 8 cm, more than 8 cm in one sac, and oligohydramnios defined by largest vertical pocket, less than 2 cm in another twin is found. Then you can diagnose this as TTS.
Correct, correct.
Yeah, and then go next. So this is the staging. You can TTS can maybe graded in severity according to widely accepted Quintero staging. So you have stage 1 until stage 5. So basically the stage 1 oligohydramnios and polyhydramnios sequence and the bladder of the donor twin is visible. Doppler in the both twins are normal, and then stage 2 oligohydramnios and polyhydramnios sequence, but the bladder of the donor is not visualized. So yeah, the key is the bladder of the donor is not visualized, and then the stage 3 only same thing, and then non-visualized bladder and abnormal Doppler. There is absent and reverse end diastolic velocity in the umbilical artery or reverse flow in AV of the DV or plus pulsatile flow in the umbilical vein, like you seen in IUGR patient. And then you can see stage 4, one or both of stage shows signs of hydrops, and stage 5, one or both fetuses have died. Okay, I'll be giving to Marwan talk about management of FTTTS.
Thank you, Farihin. Can everyone hear me?
Yes.
Okay,
Okay.
okay.
So next, we move to management of TTS. Next, Idham. Uh, Idham, can you back to my first slide after the title slide?
Okay, okay.
Okay, next. Okay. So when twin-to-twin transfusion syndrome is confirmed, management will include one is expectant management, and the second will be fetoscopic laser ablation of vascular anastomosis, and the third one is amnio reduction. Fetoscopic laser ablation is considered the definitive treatment for severe twin-to-twin transfusion syndrome, which is Quintero stage 2 and above, and the period of gestation must be between 16 to 26 weeks. If the twins is more than 26 weeks, delivery may be considered for the both twins. Okay, and then amnio reduction will be done to reduce the amniotic fluid of the recipient amniotic sac until it reach the normal level, because if Farihin explained earlier, there's one twins that normally will be polyhydramnios. So mostly amnio reduction will be done according to the criteria of the twin-to-twin transfusion syndrome. Okay, next, first we must understand what is fetoscopic laser ablation. So fetoscopic laser ablation is mostly performed under local anesthetic. So with ultrasound guidance, a 2 to 3 diameter of fetoscope is introduced into recipient amniotic cavity, and the surface of placenta will be examined. And then laser will be used to photocoagulate or burn the connecting vessels until it is occluded. And then amnioreduction also can be done using fetoscope. And then after amnioreduction and ablation of the connecting vessel, then we remove the fetoscope. Okay, so next I'll go deeper into management of stage 1 twin to twin transfusion syndrome. Okay, so a woman with no or tolerable symptom and normal cervical length, the choice of therapy, we will avoid intervention, and we will monitor twin to twin transfusion syndrome closely with ultrasound weekly, and the maternal will undergo prenatal follow-up and care, which include a session of amniotic volume weekly, and then assess of fetal growth every 3 to 4 weeks. And if fetal growth lack is identified, normally Doppler blood flow studies are do or obtained weekly. And beginning at 30 weeks, biophysical score will be performed weekly. And delivery is scheduled normally at 36 to 37 weeks if twins to twin transfusion syndrome stage and symptom remain stable. If the stage 1 twins to twins transfusion syndrome, but the women's are associated with debilitating symptom, short cervical length, which is less than 25 millimeter at 16 to 26 week period of gestation, the choice of therapy normally will be fetoscopic laser ablation. Okay. And then the prenatal and follow-up and care for women with stage 1 twin to twin transfusion syndrome with symptom will be weekly ultrasound, and then weekly ultrasound are performed for the first 2 weeks, and then after that every 2 weeks we will perform ultrasound to evaluate for any complication. And then fetal weight will be evaluated every 3 to 4 weeks to identify severe growth lag. And beginning at 30 weeks, biophysical score are obtained weekly. And delivery is normally scheduled at 37 weeks in absence of complication that need earlier delivery. Okay, and then if patient stage 1 twin to twin transfusion syndrome came with debilitating symptom and the period of gestation is more than 26 weeks, normally our choice of therapy will be amnioreduction. And then the prenatal follow-up and care will be uh, weekly ultrasound and then amnioreduction if repeated, if patient becomes symptomatic due to recurrent polyhydramnios, and then estimation of fetal weight every 3 to 4 weeks to identify growth lag, and then biophysical profile weekly at the beginning of 30 weeks and delivery after 37 weeks if there is absence of complication that need early delivery. Then we move to management of stage 2, stage 3, stage 4 twins to twins transfusion syndrome. If the maternal came at 16 to 26 week period of gestation, normally the choice of therapy will be fetoscopic laser ablation. And then follow up and care will similar to stage 1 twins to twins transfusion syndrome, which we treated with laser ablation, which I explained earlier. And then if the maternal come more than 26 week period of gestation, the choice of therapy will include amnioreduction, and then the prenatal follow up and care will be identical to stage 1 twins to twins transfusion syndrome with amnioreduction. Then we move to stage 5, twins to twin transfusion syndrome. As explained by Farin earlier, stage 5, normally one of the fetus have died. Okay, if one of fetus have died, normally the major concern will be death or neurology impairment of the other twins because of the short circulation. And laser therapy or amnioreduction cannot prevent cerebral damage. in surviving twins, and the goal of the management of stage 5 twin-to-twin transmission syndrome will be to optimize the outcome of the surviving twins. Normally, in preterm fetus, fetal ultrasound will be done every 3 to 4 weeks to follow fetal growth and certain nervous system development to actually assess it closely. And then MRI is done 3 to 4 weeks after the death of co-twin to detect any intracranial injury. Okay, that's for management of twin-to-twin transmission syndrome. Any question on that first? Okay, there's no question. Then we move to delivery method of twins based on fetal presentation. Okay, so actually there's a variety of presentation in twin pregnancy. As you can see in the picture, include vertex and vertex, which is 45%, vertex and bridge 37%, bridge and bridge 10%, vertex and transverse 5%, bridge and transverse 2%, and transverse 0.5%. So normally presentation will be vertex and vertex of multiple pregnancy. We need to know how to determine the first and the second twin. Okay, so normally to determine the first and second twin at the 11 to 14 week period of gestation, the fetus that contain the gestational sac that are closer to maternal cervix was designated as first twins. Okay, so as you can see in the example picture, so the baby on the left side of the maternal is closer to the maternal cervix, so the baby is considered as the first twin, and the other twins is vice versa lah. And then on the second picture, the uh the twins on the below is actually closer to the maternal cervix, so these twins is considered as the first twin, and the superior twins is considered as the second twin. Okay, so if the first, so we will talk about the delivery of the first twin first. Okay, so if the first twin is non-cephalic, which is bridge or transverse, normally cesarean section will be done to deliver the both twin. Okay, and then if the first twin is cephalic, but there is no indication for cesarean section, so normally vaginal delivery will be preferred for the first twin. But if the first twin is cephalic but have indication for cesarean section, for example, fetal distress or intrauterine growth restriction, so normally the cesarean section will be mode of delivery to deliver the both twin. Okay, and then if we move to the delivery of the second twin, if the second twin is cephalic, so normally vaginal delivery will be preferred for the second twin. Okay, next before I proceed, if the second twin is transverse or bridge, we will talk about internal podalic version. So internal podalic version is a maneuver where we identify the fetal foot. So normally the obstetrician will grasp and spool gently the fetal foot into the birth canal. So if the fetal part is not palpable or the obstetrician cannot confirm the fetal part, so ultrasound guidance may be need. And then this to prevent from bringing the fetal hand if the obstetrician mistake the fetal hand for the fetal foot. Okay. So if the second twin is breached, normally we will proceed with ECV. If the ECV is successful, we will proceed with vaginal delivery. But if the ECV is failed, normally we will proceed with internal podalic version. Okay. But if the second twin, this is only if the second twin is presented with complete breach or frank breach. But if the second twin breach is presented with footling breach, we will perform breach extraction. Okay. And then if the second twin is transverse, we will proceed with stabilizing the light to cephalic. If the second twin successful to stabilize to cephalic, vaginal delivery will be preferred. If the twins cannot stabilize the lie to cephalic, normally internal podal elevation is done to the second twin. This is my reference. Okay, is there any question from the floor?
Okay. Any question? The mode of delivery as mentioned by Marwan,
Yes,
that's
ma'am.
that's correct. Okay. But as long as the baby, the first twin, okay, in Catholic presentation, we can opt for the general delivery. For C-section, those with non-Catholic in the first twin. So Catholic presentation in the first twin, okay, we can allow for vaginal delivery. But after the first twin delivered, okay, the one that with Catholic presentation just now, we have to reassess the lie of the second twin. Make sure the lie of the second twin in longitudinal line, whether in breast presentation or in Catholic presentation, as long as in longitudinal line. And during the contraction, okay, rupture the membrane, and you may deliver the baby with Catholic or with assisted breast delivery, as long as in the longitudinal line. If the baby in the transverse lie after the first baby delivered, so you have to do external version to make it in longitudinal line. Okay. If during the process of external version and suddenly the membrane is ruptured, and then you have to put the patient in the lithotomy position and insert your hand into the uterus and grab the baby's leg and direct the baby's leg into the introitus and deliver with breast assisted delivery. Okay. If you fail to do the version externally, and then you decide to do internal podalic version, then do it internally with membrane intact. Once you're able to grab the baby's leg, okay, only then you rupture the membrane. Okay, or you grab the baby's leg and direct to the introitus and rupture the membrane and deliver with assisted breast delivery. Understand? Faham kan?
Yes, Prof.
Right.
Faham,
Any
Prof.
question? All right. Continue.
Actually, Prof, at the end of our presentation, I was the last presenter, Prof.
Okay, okay. All right. So your team only concentrate on TTTS and the management. Okay. Lot of issue in twin gestation. Okay. Triplet we don't discuss lah. Triplet, quadruplet. But in twin, for example, a condition we call as TAPS. Okay. Anyone know about TAPS? Twin anemia polycythemia syndrome. And TRAPS, twin reverse atrial perfusion syndrome. This is related to the twin pregnancy. Another one problem regarding twin is selective IUGR in a twin. There is no twin to twin transfusion, but one of the baby is small and the one is bigger. Okay, so we call as relative small IUGR in the twin. Okay, and a lot of other issue regarding the diagnosis of chromosomal abnormality in twin. Okay, in the first trimester you can do certain tests. In the second trimester you can do certain tests, but there is too detail for your level. So hopefully you go back and read about the twin from the 10 teachers and from other relevant reference. If you want to read more, then you can search from the internet. Appropriate resources about the twin. Probably you may search what we call publication article, a well-known article that being quoted, majority ataupun mostly cited in in the journal article about the twin. So hope you are enjoying in the ONG posting, and I wish you all the best in the exam. Do you have any question?
No problem.
Ada soalan?
Faham.
Faham?
Tak ada. Faham.
Okay.
Thank you, bro.
So we end up here, right? Okay. So best of luck in your posting exam. Bila? Tomorrow?
Tomorrow, Prof.
Tomorrow, Prof.
Okay. All the best. Okay, thank you.
Thank you so much.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you, Prof. Thank you, presenters.
Thank you, Prof. Thank you, presenters.
Welcome. Shut up now. Oh.